Good morning, one and all. We welcome you all to the International Webinar Series on Holistic Health, Well-being and Sustainable Development on occasion of World Social Work Month and also World Health Month 2022. This webinar series has been organized in collaboration with Sri Holistic Health Foundation India and Sri Research Institute and Center for Arts, Sciences and Well-being. So today we have with us an eminent resource person, Mrs. Sharada Lingaraj Garu. So before we continue with the proceedings, let's take the blessings of Almighty.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
With the blessings of Almighty, we shall continue to the proceedings of today's webinar. Sharada Garu, can you switch on your audio and video?
Yes,
so
sir.
Will you be able to present or need some assistance?
I think I'll be able to present, sir. Thank you.
Okay. So can you try it once, ma'am?
Yeah. So you tell me if I'm able to share the screen, sir.
Yeah. It's visible, ma'am. Introduction to palliative care.
Yes.
So this is the first slide.
This is the first slide.
Can you just move on to second slide so that we can see? Yeah. Okay, slides are moving, ma'am.
Yes, sir.
Can navigate to the first slide.
I can start right away, sir.
Yeah, let me introduce you. Yeah. Welcome all once again. Today we have eminent resource person, Mrs. Sharada Lingaraj Garu. She is hospice administrator and also a psychologist. She has more than 6 years of experience in the field of palliative care, serving terminally ill patients. And she is also a psychologist and counselor, presently working with Sparsh Hospice, Hyderabad. Over to you, ma'am, for your session on need for palliative care in health industry.
Good evening, everyone. Thank you for this opportunity and I am very happy to be on this platform, sharing my views on palliative care and why we should own it and propagate it. So before we really discuss about what palliative care, I'm going to the second slide. First, we need to understand what the World Health Organization says what palliative care is about. So it says that it is about improving the quality of life of a person and their families who are facing life-limiting illnesses. How do we do that? How do we improve the quality of life of patients or their families? By managing their pain and managing their symptoms, detecting, trying to prevent them to start with, and then assess them properly and treat the pain and other problems so that the quality of life of the patient and the family improves. So when we go to the first slide, you can see here, then we need to understand why there is a need for palliative care presently. How come it was not there earlier, and how come it's started only in the recent past? And why in Indian scenario it is still struggling hard to survive or offer its best possible care for the patients. So who needs palliative care? When a person is diagnosed with a terminal illness or a life-limiting illness, like predominantly cancer or lung failures, kidney failures, liver failures, either due to their habits or due to genetic factors or any other lifestyle factors, once they are terminal, that means the treatment options are closed for these patients. Then there should be a way where we can help them live with the dignity and quality of life in spite of the disease. We hear many of our colleagues and friends say that I wish I have a heart attack and die peacefully. Because most of us are not afraid to die, but we are afraid of the process. We don't want to experience that pain because general information or the general knowledge of everybody is that death is associated with pain. That's the reason many of us are scared, worried, we feel anxious. We don't want to talk about it. There is a lot of taboo attached to it and all. So how do we improve that situation? By addressing those issues. So who needs these, addressing? Once a person is diagnosed with some sort of terminal illness, that person needs, and apart from that, even the elders, the aging population. When we say the elderly, we are not talking about just simply geriatric care, wherein the elder population is taken care for their feeding and other requirements. I'm talking about the health-related issues that are associated with aging. Even these people need palliative care. And people who are actively dying, all these people need palliative care to ascertain or to ensure that they don't die a miserable death, they don't die a very bad death. So that's where we are going with this particular presentation. And palliative care and palliative medicine, they're two different things. When we say palliative medicine, we are talking about the physical pain and the physical issues of the person who is suffering with some sort of an illness or a health condition, or because of his age, the health-related health conditions because of the age. When we are talking about all those things, palliative medicine deals with the physical aspects of that particular pain. But palliative care is a much broader term than palliative medicine, in the sense that people who are suffering with a disease not only experience bodily discomfort in terms of pain or different symptoms and wounds and things like that, but they experience pain on different planes, which we'll discuss in the future, in the upcoming slides. So unless we address those things, we cannot call that a complete or a holistic care. Say, for example, someone has a headache and he wants to get back home. And a cup of coffee, he can help himself with a cup of coffee and, he might feel better. But the same cup of coffee, if it's coming from his loved one, so the psychological aspect of that particular care adds so much value to the person, value to the patient, that he experiences little more relief than what he can help himself with. So that's where we are talking about the psychological component or the caregiver component of the patient care. When a person is diagnosed with a disease, it doesn't affect just that person, but it affects the whole family and his community. When we say his community, his friends, his relatives, his extended family, all those people. So when all those people are affected, how do we ensure their comfort? Unless all of them are also equally comfortable, the patient cannot be comfortable. So that's where the palliative care will come into, come in to help the patient and the families to ensure their psychological and physical comfort. So palliative care is about empowering a person who's fighting a disease to live with dignity, to ensure quality of life for himself, to ensure that the disease doesn't start dictating his lifestyle, but there is some sort of control left in his hand, wherein there is a provision for him to manage his pain, there is a provision for him to manage his symptoms and things like that. So palliative care is about adding that extra layer of care to the family in taking care of their loved one. Palliative care is about empowering the caregivers or the families of the patients in taking care of their loved one. So palliative care is a very, very broad term, and it's an ever-evolving area. The more you're associated with it, it has a way of not only changing the personality or the outlook of the person offering this palliative care, but also making the term, broadening the term for the care provider also. In the beginning, when we were offering care at care, it was mostly about patients who are cancer patients. So because why we predominantly talk about cancer patients is because they have pain component on a very high degree. So when we talk about pain, so that is the reason most of the palliative care centers talk about cancer patients. That's the reason that there is a misconception that palliative care is only for cancer patients. As we work more in this particular field, we try to understand the difficulties and the issues related to other diseases. We also need, there's very little understanding about the patients who are suffering from, different types of dementia, Parkinson's, or, different types of organ failures. We have very little knowledge as non-medical people. So how do we help those people? If they're not cancer patients, don't they deserve some sort of compassion? Don't they deserve palliative care, wherein we can work towards their dignity and quality of life in their end days? So this work itself not only helps the beneficiary, that's the patient and the family, but also the care provider. It makes you take in more volume from different areas of health sector. So that's what happens. So when we are talking about palliative care, the two questions that we need to ask is, everyone has a set of skills and knowledge, and how do we use that set and skill to help that particular patient? Is it the responsibility of the care provider, or is it just the responsibility of the family to offer care to the patient? So if you think on a broader level, we need to understand that it is a social responsibility of everybody in the community to help someone who is suffering with a life-limiting illness. So how does, in that, when we understand and when we own that particular concept, then the next question is, how can our skill and how can our knowledge reduce that suffering for the patient? It's not about showcasing our skill or knowledge. It's about how can I translate this skill of mine, this knowledge of mine, to the benefit of the patient. So that's the first question. The second question is, we should also empower the patient and the families in such a way that they can draw strength from their community. We can empower them in such a way that they know what to ask for and how to ask for and when to ask for help. Generally, in Indian scenarios, my experience in this particular field showed that it's very difficult for many people to ask for help, especially in health-related issues. There is so much of gender bias also here. Say, for example, if a wife says that I'm not able to take care of my husband, probably she could have served him for, 2-3 years by then. And, if she has admitted to you or to a care provider that she's not able to do it anymore, it's very natural for everybody who is, listening to that particular conversation and judge her very fast. We don't understand the concept of caregiver burden. We don't understand that even the care provider needs a respite, needs a break once in a while to recoup and again restart the duties of a caregiver. So here we have to educate and empower the community. When we say community, we are talking about the facilities that help the person, the family and the patient in taking care, in alleviating their pain and, and symptoms and things like that. Not only that, we need to empower them with what sort of help they can get from other support groups. What are the other, resources that are available to them, how they can be, procured or, approached. All these things we have to empower. We have to empower the families and the patients and the communities surrounding them to see that the patient is comfortable in the limitations of the disease, within the limitations. Ultimately, we have to see the person. The ultimate purpose of palliative care is to make everybody see the person and not just the patient. A person is a patient only in one particular on one particular level. Once he crosses that, he's a person, he has his own feelings, he has his own insecurities, he has his own dreams, he has his own, passions and things like that. When a disease cuts short one's dreams, it cuts short one's aspirations and, things like that, his own life, it shortens his life. It has its profound impact on other domains of well-being, like psychological well-being is affected, the social well-being is affected, and even the spiritual well-being is affected. So palliative care ensures that within the given limitations of the illness, how to attain, psychological well-being, social well-being, and spiritual well-being. This is what a palliative care is meant for, and this is the very reason that it has to be integrated into our medical systems in such a way that it is patient-centric and not a medical system-centric. When we say patient-centric, it is more about taking decisions, taking calls to suit the requirement, to suit the capacity of the patient. So palliative care doesn't come at the end of the line of treatments that the patient has access to. Say, for example, if you take cancer, many people think that, okay, let me first try chemotherapy, then we go to radiation, then if the surgery is an option, let's go for it. Then if it's not that, then so many other treatments are there, immunotherapy and, then hormonal therapies and, target therapies and so many technical terms, so much of, interventions are, coming up and they have so many options. But one thing that eludes the families or the patients is that, are they really effective for them? Is it really, are all those options effective and suitable for this particular scenario? This is where the medical fraternity or the people from palliative care are expected to sensitize the patient about the utility of that particular intervention for their loved one. Unless this is done, there is no true palliative care. Unless it is done, the palliative care will be seen only as a last option of, medical line of treatments. What I'm trying to say here is that, say, for example, a patient is diagnosed with cancer and he's 85 years old and he's very, very weak. There is an option for chemotherapy and radiation. If the family or the patient decides that We don't want to take up those options. Then the patient should be made aware of the option called palliative care. Unless it is made available, the patients are pushed towards interventions that are not really useful for them. So this is not being practiced to the extent that is expected to be practiced. So this is where we feel that palliative care should own the limitations. The medical fraternity should own the limitations of the patient and their families while advising treatment options for the patients. So this is, if this is done, palliative care will automatically become integrated with the medical practices that are prevalent in our country. So when we go. As we have already discussed, palliative care is an attempt. We make an attempt. We make a 100% attempt to see to it that he lives well with the disease. No, he lives with the dignity with the disease. So when we say he lives well, what are we actually talking about here? What makes a person well if he's already suffering with a disease? If the medicines are not able to cure him of the disease, then what is the question of well-being redundant? So palliative care says otherwise. It says, in spite of the limitations of the illness and the disease, we can still encourage the patient to be physically well, emotionally well, socially well, and spiritually well. How do we do it? To ensure physical wellness, we need to understand the implications, the physical implications of the disease, and address those implications, address those symptoms, reduce the symptom burden, reduce the pain level for the patient, wherein he can still enjoy his little routine, he can still enjoy the fact that he's still alive, still be aware that he's the person that he was even before the disease struck him. So that is the role of physical well-being. That is how we ensure, by giving medications, by giving nursing care, and by symptom control. The different symptoms are there. We'll come to all those things in the next slides. So by addressing all these issues, we can ensure biological well-being or physical well-being. Then how do we ensure psychological well-being? When we say psychological well-being, we need to understand that when a person is informed that he has been diagnosed with cancer, his entire world collapses around him. It affects him because, in general sense, people equate cancer with death. Once you're diagnosed with the cancer, that's it, you're going to die. Even though you try treatments, the end result in most scenarios is death. That too, a very painful one. So the entire process of death, the entire dying process comes, right in front of their eyes, and they're very, psychologically depressed, anxiety, anxiety issues, and, they're withdrawn, they go into social isolations and things like that. So we need to address all these issues by listening to his side of the concerns, by being open to his concerns, by being non-judgmental for his concerns. Everybody is entitled to their lives. Everybody is entitled to their pain. No two pains are the same. That's what my experience has taught me. Same scenario, same thing, two different people take it in two different ways. Still, to remain non-judgmental and help them out to face this unexpected situation, unexpected disease, in a way that they're proud of themselves, that in a way that they don't lose their own image, in a way that the society still respects them. So that's how it's done in palliative care, by manage their physical, psychological well-being. For that, to do all these things, palliative care is offered professionally by a multidisciplinary team, wherein there are doctors, where there are nurses, where there are nursing aides who ensure, the actual physical care of the patient. And there are social workers, there are counselors, there are volunteers, and there is community. All these people ensure that the patient is doing good on all these planes of physical plane, emotional plane, social plane, and spiritual plane. When we are talking about social distress, it is still very heartbreaking to know that there is so much of taboo and so much of, like there are so many rumors and so much of misinformation that is attached to cancer. People think that it is still contagious. People coming from rural areas express that they have been, separated from their tribes. They have been, they're not encouraged to attend any festivals. They're not encouraged. They're not invited for any, festivals, family functions, and things like that. Within the family itself, they are kept separate in a room. They are not recognized the way they were. The dynamics of the relationships change, and they lose their own identity because of the disease. So this affects them profoundly. Recently, we have met a patient who said that my plate and glass is marked red in the house and nobody uses it. Why, ma'am? Why? Why do they do that? My son, who was loving me till then, right now doesn't even, come near me, sit by me, and touch me. They don't touch my plate or glass. Is the cancer contagious? So a lot of work needs to be done to, to educate people that cancer is not contagious. So much of work parallelly is happening. Though it is happening, the belief is so very deep and profound that the efforts that are taking place are not able to, bypass that belief. So there are occasions where a tenant was, kicked out of the house in the middle of the night because he was not doing good on that particular evening. Because we believe that when somebody dies in that house, the next tenant will refuse to come, or depending upon the time and things like that, that house has to be kept shut for some time. All these beliefs, they reduce the dignity of the person. They work against the dignity of the person. They're suffering, they're in a lot of pain, they don't know, they have no control over their life suddenly because of the illness. But they're still asked to get out of the house because he's suffering for no fault of his. So there is so much of social trauma, they lose their livelihoods. Suddenly they are no longer the head of the family. They're suddenly the family dynamics change. Probably the husband leaves the wife, or probably the wife takes away the children and goes off to her mother's place. And children disown, they leave them in the hospitals and go away. All these things keep happening. So this social discrimination adds a lot of stress to the patient. And palliative care, it is addressed by the professionals, by the team that works closely with the patient. Then the most important thing is the spiritual care. When we're talking about the spiritual care, it is about the existence of the person. It's about finding a reason to live in that stressful situation. Suddenly, imagine a person who is 40, 50, he's having a good life. He has a good family, he has a good job, and he's very happy. Suddenly he's diagnosed with terminal illness. Suddenly disease is diagnosed and he was informed that nothing can be done about it. General belief system is that you be good, good happens to you. You be good, God takes care of you. When that belief is shattered, I have done nothing wrong. I haven't touched alcohol, I haven't touched cigarettes, or I don't have any sort of bad habits. How come this is happening to me? What's wrong? So is it really not enough to be good? Is it really not enough to do the right things? So if nothing is in our control, then why be like this? So the value systems, the ethics, the moral values of the person, he starts questioning himself. He loses hope. He entertains the thoughts of suicide because the entire belief system has collapsed around him. He no longer thinks what the life he has led is correct. He no longer thinks that his beliefs have helped him in any way. The God hasn't helped him in any way. His religious beliefs get questioned by himself. Nobody else questions. He himself questions. When that distress happens, that is the spiritual distress. He is trying hard to find hope for himself to live, to have that will to fight in that distress scenario. Sometimes it's not possible because, in spite of all the work that the person has put up, and in spite of all the options that he has availed and things, nothing has worked in his favor. So then why do it? Why live this life? So when the end result is death, why not end it sooner? When God himself has gone against me, and who is anybody to help me? There's no one who can help me. So why not go? So these sort of thoughts, wherein he feels hopeless, wherein he feels that there's no one who can help him, wherein he loses trust in the system, he loses trust in the will, God, his own religion, all that. That is the spiritual distress. When we say palliative medicine is different from palliative care, this is what we mean. Palliative medicine takes care of the physical aspects of the disease implications, that is the pain and the symptoms. Whereas palliative care is like a holistic way of looking at the person's distress. It ensures a level of emotional well-being, a level of social well-being, and a level of spiritual well-being. Say, for example, there is an auto driver and he makes 500 rupees a day. He comes home every day with his vegetables and all the groceries and things like that. Because of his tobacco habit, he is diagnosed with cancer in his mouth. Over a period, all the treatments have failed and suddenly he becomes bedbound. We are giving them medicines. We are giving them pain management medicines. We are trying to dress his wound and we are ensuring that all his symptoms are under control. The symptom burden is lessened. All these things were ensured. Do you think that seriously it will help him be a content person just because his issues are handled at physical level? In most scenarios, no, because he is witnessing his children going hungry. He's witnessing his wife struggling to lead a life when he's bedbound. So all these things will add stress to his emotions, his spiritual well-being, all these things. So this is where palliative care is about a professional team offering all these things to the patient and the family with the community involvement. There is a professional palliative care team in a particular place or in a particular hospital. They cannot ensure social well-being of a person because they will have their own limitations. When the community joins hands with that particular team or with that particular facility, we will be able to offer that social comfort where education of the children is ensured, food on their table is ensured, a place for them to stay if it's a rented facility. If they're asked to leave that particular facility, a place is ensured for them where they can stay and die in peace, literally die in peace. So that is where the community involvement is very, very, very essential in offering palliative care to a person with life-limiting illnesses. It's not one person's job or one team's job. It's a job of a community. We are all social animals. We are expected to look out for each other, and disease is one aspect wherein the community has to come into the patient's life and try to offer support to ensure his overall well-being. So this is when we say palliative care is holistic, this is what it means. So if you go to the next slide. The medical domain, as we have discussed already, whether the disease is curable or not, we should be able to control the symptoms. When they say that disease is curable or not, I need to bring to your notice a small difference between two words, as palliative care and hospice care. So when a person is diagnosed with a disease, his treatment starts. So he's in a line of treatment. And because of the disease and this treatment, he experiences certain symptoms like vomiting, nausea, or some sort of incontinence, confusion, or any of these symptoms that are mentioned on the slide. The treatment is happening. An attempt to cure the disease is happening. And because of the treatment, he's experiencing certain symptoms, some extra burden. That is addressed by way of medical, by way of medicines and things like that, some sort of interventions and procedures. Then it's called palliative care. Palliative care is the support care or the comfort care that is offered to the patient from the time of diagnosis of the illness. Somebody sits with him and explains that how the disease, how we can support him in his travel, in his treatment methods, in his travel with the disease, how we can support him, how we can support his family. If this is happening right from the diagnosis, then it's called palliative care. Sometimes it so happens that the treatment ends and the disease is not cured, and still he needs that support care. That particular support care is called hospice care. So the basic difference is most of the palliative care patients are under treatments, but still they get that support care. Hospice patients are the ones who have no treatment options. Their treatment options have closed, and their dying process has started, but still they need that palliative care. Those patients, that particular care is called hospice care. There's a slight difference, but both are almost the same in terms of the care that's being offered: the physical care, the emotional care, the social care, and the spiritual care. When we are talking about the medical symptoms and medical physical side of the disease, there is pain, there is nausea, vomiting, wounds are there, bed sores, incontinence, confusion, breathlessness. All these are addressed with the help of medicines and procedural interventions. Why do people generally associate palliative care with cancer? It is mostly because of the pain burden. Pain is the most, the largest volume of patients face or experience excruciating pain that cannot be managed with the medicines that are bought across the counter. So if you take number of patients, it says most of the patients have percentage of 35 to 96 pain. That's a very, very large volume. So palliative care mostly is pain management. Physical side of the palliative care, palliative medicine is pain management. When we talk about pain management, there are different ways of managing the pain. There's so many interventions, there's procedural interventions and things like that, and there's narcotic usage in pain management for these people. So when generally there is a lot of misconception, even in the medical fraternity, about the side effects and the usage of the narcotics. I've seen many people not prescribing narcotics with an intention that it would spoil their kidneys, spoil their liver, it makes them addictive and things like that. But when we weigh the burden and the benefit, the burden of the side effects and the benefit of that medicine, we need to take a call that is in the best interest of the patient. It is true that overuse, if you use those medicines for a very long time, it would do all these things. Probably it would damage him, the patient will become addictive and things like that. But does the patient have that long? Is the patient going to live that long? When we weigh that particular scenario, then generally the team leans towards narcotics. And because these narcotics come as, they are restricted substances, they're available only with few people. That's where these patients suffering with these illnesses go to those centers and to get those medicines. So unless these medicines are used, the pain of the patient is not at rest. Unless the longer the association of the person with the pain, the deeper the issues on emotional level, social level, and even the spiritual level. If a person is experiencing pain for one day, he's tolerant about it. He's hopeful that tomorrow is going to be better. If it happens the next 1 week, then he starts thinking, is it going to be like this for a long time? So the longer this, then he will think on the lines of, why is it happening to me? Well, I haven't done anything wrong. So what will happen to my family and kids? And if this pain is not reducing, do I jump and go up and jump from the 10th floor or 15th floor? So the longer the association of the patient with the pain, the deeper the issues. That's the reason pain needs to be managed according to the expectation of the patient. Pain is what the patient says. If the patient says that the pain is very excruciating, it's not for us to judge that he's either pretending or he's just, hyping it up for different reasons. We have to take his word and administer the drugs accordingly. So pain management is one of the very crucial aspects of managing the physical well-being of the patient. Then there are so many other symptoms like depression is there, anxiety, confusion, fatigue, breathlessness, insomnia, nausea, constipation, diarrhea, anorexia, inability to eat. All these things are there. Eating becomes a very big concern for terminal patients. It's a concern of the families. During our practice, we see that if the patient doesn't eat, the family gets very distressed. Suddenly their understanding of the disease, suddenly the prognosis of the disease does not have any, does not bring any value to their thoughts. They suddenly think that they're not eating anything, just see that they eat something. The thought stems from the very belief system of ours that we show love and affection to our loved one with food, with physical contact and things like that. Once we are not able to express our care to our loved one with food, it distresses the caregiver. They become so distressed that most of the cases, they even feed the patient against medical advice. It cannot be stopped sometimes. We try to tell them, but that need to feed is so very profound that they do feed the patient against the medical advice. So feeding is very, very, very crucial for the feeding for their loved one is very, very crucial for the caregivers. So in the end of life scenario, everything suddenly becomes about feeding the patient. If the patient is eating something, it translates to being normal for the caregivers or the families. If he's not eating, that's very grave for them. They're unable to accept that the time is nearing, and they fight it out a lot in terms of requests for different types of feeding methods. Some people, even the patient is 90 years old and he's leaving, he's not conscious. They ask us, why don't you put a tube through the nose and see that we feed him? Even when we explain to them that it's futile to do that at that point of time, the one very profound statement that I heard recently is, oxygen and food is something I'm not going to deny my parent because of its futility. It doesn't matter. Even if it's futile, I want to continue to do that. That's the strength of their emotion when that feeding comes for their loved one. So, and in palliative care, as we said, it's not just about the patient, it's about the family also. We need to do things which comforts the family givers also, as long as it is not affecting the patient in a negative way. it's fine. It's okay to do small things like, if the family is comfortable to have the feeding tube inserted so that something goes in for the patient, then it shouldn't be okay. It cannot be all technical. We cannot be all technical about it and try to tell them. We try to tell them. If they're not okay with that, we should allow them to do. We should facilitate what they're expecting us to do. So that's what palliative care is about. Because for us, he's a patient. For them, it's their loved one. Their life is going to change on a bigger level. Their connection with that person is very deep, unlike us. So we need to honor all those wishes. So suddenly that's one of the physical components of the pain. Palliative care. When we say palliative care is not just for non-cancer patients, the sentence says that it's not just cancer symptoms experienced in the last year of life in non-cancer conditions. For non-cancer patients, it's all the more difficult is what I think sometimes. The consistency of the problems for a very long time, it brings down their quality of life. It raises many ethical questions. It raises many, abusive behaviors. All these things come into play for the non-cancer patients, because for non-cancer patients, the duration of their life is very long. They'll be fighting with some sort of a disease, and their duration is very long. Unlike cancer, which is progressive and eventually it just peaks and they pass away in few years. Certain non-cancer patients, like say for example, a stroke patient. Stroke patient is there and he's unconscious, and the family is finding it difficult to take care of their loved one because they're not able to leave him, they're not able to go and work, and they're not able to have an attender take care. There's a financial implication to entire care, all these things. So when we look at all that scenario, it's not just about the last year of their life we are discussing here. It's about a long period of their life. So it's very, very essential that the non-cancer patients also be brought into palliative care because of their different aspects of symptoms and things like that. Pain. If they say cancer patients experience 88, pain is 88% of the cancer patients have pain. Even heart disease patients have 77, and stroke patients experience 66. If you take pressure source, cancer patients have 28%, heart disease 11, and the possibility for the stroke patients is 20. Bowel incontinence is high, both in cancer and stroke patients. Mental confusions. So if you see the different aspects of it, the scores remain almost the same. They're not that much variant, but still the general thought is that only cancer patients need palliative care and not other patients. That's where a lot of work is being done by many professionals to bring in, to understand the difficulties of the patients who are handling non-cancer patients, especially families who are fighting, the patient who is fighting with dementia, like, Alzheimer's or any type of dementia. For 7-8 years, the quality of life of the entire family comes down. Suddenly it all becomes about the patient. And 7-8 years is a very, very long time. So many things can change. The quality can change. The care, the way we think about the patient can change. The way we care for the patient can change. And the caregiver might be so overburdened that he doesn't even realize that he's being insensitive. He doesn't realize that he's not offering good care, quality care. So that's the very reason that we are working, all of palliative care field people work to bring in all types of illnesses wherein some quality can be brought by managing their physical symptoms, emotional symptoms, or social and things like that. So all the more reason for us to be sensitive to the needs of all these people and the families who are fighting these illnesses. So families lose so much in the process of taking care of their loved one. And we need to acknowledge that loss. We need to acknowledge their pain in taking care. Being a caregiver for a very long time is a very, very tough role to play. It is like keeping yourself on your priority, you keeping yourself last in your own priority list. The patient comes first. In that process, you lose yourself, you lose your sensitivities, your entire personality changes. And your finances are affected, your life is affected. So we have seen many families where the children remain unmarried even at the age of 40s and 50s, because not by choice, because they were busy taking care of their loved ones and the time has flown by. They never realized that. And these things we have to be sensitive and see to it that as a palliative care team, palliative care professionals, what we can do for those families. So how does a community help for these sort of families? We need to identify the resources for them. We need to be aware what's happening in our communities, in our neighborhood. If somebody is suffering in a way that it is affecting their lifestyles, we need to understand how we can help. How does community help a family or a person who is suffering? By identifying the resources, by acknowledging that it's our responsibility to help with those people. So when you identify the resources, like there are government hospitals who take care of these patients, or there are certain facilities who take care of their patients, understand their limitations. To understanding their limitations is very, very essential. If they have the capacity to pay, we can show them some resources where care is offered at at a price. If they're not financially doing good, then we need to identify and then show them the places which offer this sort of care, this particular care, free of cost. So this becomes our social responsibility to ensure that even non-cancer patients get that type of attention, get the type of love and care from the community. If you look at this particular slide, it just shows that, one second, sorry. What are the different types of diseases and World Atlas? So liver diseases, so much of percentage, I believe, and renal failures, premature birth and birth trauma. If today we are discussing about all these diseases or all these medical conditions under the purview of palliative care, it's after tremendous hard work of palliative care, a tremendous hard work of physicians who have believed that palliative care is meant for everybody. Palliative care is a right of everybody. So from that thought, previously it was just for cancer patients or for some very serious life-limiting illnesses. Here, if you see, it is like, degenerative diseases wherein the persons will live for a very long time. Okay, and then injury, poisoning, external causes. If the injury is there, then we say that you take him to a hospital. It's as if they don't need any type of care. A hospital takes care of them, he gets better and he moves on. The trauma leaves a permanent imprint on a person's life, whether it is a trauma of the disease or trauma of an accident or, trauma of any of these illnesses. So how do we address all those things? By owning the pain that is associated with these diseases, by understanding that any type of illness, if it is prolonged, it should be brought under the purview of palliative care, where we can offer them comfort, where we can offer them support in a way that they're not burnt out. We see many cases. Recently there was a case. He was 40 years old. He is 40 years old. He is an alcoholic. He was flying kite and he fell down from third floor and he became paraplegic. And then his parents are very elderly. Father is not doing good, and mother works as a domestic servant. So how do we help such type of people? Can we say that they don't deserve palliative care because he deserves it? He is, he's an alcoholic. He was irresponsible. How could he do that? How could he go up and fly kites after taking alcohol? He should have been responsible. He is not an young kid. So can we afford to judge a person like that? Are we saying that Our care is conditional. If you're a good person, if you haven't, there's no part of you in getting the disease, only then we'll help you. Otherwise, we won't help you, especially in liver cirrhosis and things like that. It comes from, alcoholic behaviors. So can we say that? So is it really ethical to say these sort of things? So many physicians have worked to encompass all these diseases and all these illnesses and ensure that all these are brought into the purview of palliative care. All these people have a right to have a comfortable end of days or comfortable recovering processes, or comfortable association with that particular event, either it's an injury or that particular poisoning and things like that. So a lot of hard work has gone in, and that's the reason that presently all these diseases in the world are generally handled in palliative care. If you can say tuberculosis, HIV diseases, hemorrhages, and chronic heart conditions, all these things come under the purview of palliative care. When we say psychological domain, we need to give emotional support to the patients and the families. The very word initially that the patient is going to die, or the patient has been diagnosed with a very serious illness, it destroys the peace of mind. It destroys the dreams of the family. It destroys the entire family setup. Then it destroys the family relationship dynamics. So how do we support it? By facilitating an emotional support with the help of professional teammates. Like there are counselors and social workers who sit out with their family, try to understand the implication of the disease on their family, the implication of the eventual death on the family. So we need to understand, is it the death that is scaring them, or the after death events that are scaring them? Is it because they're not ready to face the situation, or is it because that they're going to be left helpless on the roads? We need to understand, evaluate. We have to be very, very, this is where we need to talk with them. When we say we talk with them, we need to actually make them share their thoughts, facilitate a scenario, facilitate a situation wherein they can share their thoughts, share their fears with an assurance that they're not being judged. It's not easy to share. It's very difficult to share. It doesn't come easy for everybody. Some people are taught that sharing is difficult. You need to manage your own issues. You cannot come running to somebody. So to help them open up, to share their issues, share their concerns, we need to sit, spend time. We have to be very, very compassionate with them. We need to understand them from their perspective. We need to be non-judgmental about their scenarios. We cannot suddenly feel that, oh my goodness, this guy is crying out like this now. But when he was losing, what happened to all this wisdom? Yes, these thoughts would definitely come. But that's where we need to, hold that thought, not voice it out, not let it seep into the care that we offer. So we need to be very, very conscious of our own thoughts about that scenario. We need to be very conscious of the needs of the patient, how we can help him and how we can make the situation better for the particular patient. So we need to keep the communication open with the patient. And in palliative care scenario, the mental situation or the physical situation or any of those domains that we discussed so far, the 4 domains, physical, emotional, social, and spiritual domains, they constantly are in fluid state. They keep changing. We spend hours together today. I'm assuring him that we are there by you. We do this. We can, this sort of support system is there for you. Tomorrow morning, bang, they can be with the same problem to you and say that we are scared about it. We are not. that cannot be taken as a reflection on our capacity to help them. It should be, we should understand that the disease being such a life altering thing for them, unless unless that particular issue is addressed multiple times, it is difficult for us to instill that sort of confidence in them that those issues will be facilitated. Those issues, the solutions, or the advices that we have given, or not the advices, the solutions that we have proposed will come into action eventually. So we need to earn their trust. We need to ensure that their issues are taken care of in the limited scope of our capacity to the best of our ability. So we need to understand all those things by keeping the communication open. And there are healthcare professionals like psychologists, social workers, all these counselors. They sit out and talk with them and understand their issues and facilitate their psychological well-being for them. And the social domain, this is a very, very important, most neglected domain in the general healthcare system. In the general healthcare system, it's all about curing and getting the patient back on his feet to start his life back. But there is so much going on in his life or in his own community or in his family that most of the medical professionals don't understand, and that they don't tend to give any importance to that. So because of the disease, as we have discussed, there is still this social isolation. They're boycotted by their communities. They're not invited. They're not owned. They're not included in their festivals and functions and things like that. So they experience a social isolation. We all have, as normal, healthy people, we have experienced a social isolation and the impact of that in this COVID period. We know how it can affect us, how it has changed us, how it has, changed us on a permanent level in certain issues. So whereas in the disease, social isolation should be addressed. We should, try to talk it out with the families as why this is happening, the reason behind that isolation. We have seen situations wherein, marriages were cancelled because the father was diagnosed with liver cancer because of his habits. The daughter's marriage is stalled and, cancelled by the groom's families because they think that it is contagious or it can come to the next generation kids. Because of that, the entire family is boycotted by their communities. And there are problems caused by the gaps. What sort of gaps are we talking about? Say, for example, a patient is there who is not financially very secure. He needs to go to a hospital for treatment, or he needs to buy certain medicines which will help him stay comfortable. But he doesn't have transportation. He doesn't have money. He doesn't have anyone to take him to the hospital because his wife has to go to job, and if she doesn't go, probably there's no food on the table. So these sort of gaps in this community around him create a social distress for that person. There's no one to help him out. So this is where palliative care needs to work hand in hand with that community and palliative care setups that are there, professional setups that are there. They have to work hand in hand to ensure that these gaps are filled. We need to understand these are the day-to-day ground level difficulties or the realities of the patient families. Recently, there was one patient who was far off, who didn't have, his wife was working for 25 rupees an hour in a printing industry, and he has 2 young children. And he called us and said, I'm not comfortable, I'm in severe pain. Why don't you send me some medicine which I will take and I'll die? I might not be helping my wife, but I'm causing a lot of distress. And she can't bring me to a palliative care facility because we can't afford the ambulance. So what should a community do? What's our responsibility? Do we say that because we haven't experienced that sort of difficulty, we can be, insensitive about them? or should we take responsibility and ensure that the patient is given that sort of support in the end days of his life? How does a community become a healthy community? Only when there is a cohesion, there is a strong bond between different components of that community, different components of the society. Only then there is a holistic approach that can be offered for the terminally ill patient. I think this particular statement can apply to any domain of your life, not just the medical thing, I think. So there should be a cohesion. There should be some sort of informal and formal support systems that can help the patient. It could be a continuous support. It could be a one-time support. So we have to look into it and understand it and make it possible for the patient to get the help that he deserves. And the final solution is a society which works towards the well-being of all its members. This is such a big social responsibility of everyone, not just one person who is suffering or the family where a person is suffering. It's everybody's responsibility. So I think that's the reason many NGOs take up different causes, like, there are societies who take care of, stroke patients. There are societies which thalassemia patients, like one society is there. And there are societies who work for the terminally ill cancer patients or terminally ill patients. And there is a government policies are in place. So why all these components? Because it is everybody's job to ensure a communal well-being in their own respective communities. So it is everybody's job in terms of, we might not be able to offer care. We were not equipped with the skill or the knowledge, but we are equipped. We should equip ourselves with the resources, knowledge of the resources, and pass it on to the people who deserve it. And we should equip ourselves with a thought to be compassionate to them, to be understanding towards their problems. It's not my problem. I've heard many times people say, how much can you do for these people? How much ever you do, there's no end to it. If not this patient, there is someone else always looking for help. But no, the ultimate thing is do how much ever we can. We cannot resolve everything. That's the truth of it. We cannot. But probably we can be responsible enough to take care of 3-4 people or some people. So that's where volunteers come into place in a palliative care setup. They are like the backbone. They fill those gaps. They are the ones who help us fill those gaps. If a patient has to be brought from a far off place, they are the ones who support the ambulance bills. And the worst part is that by the time the families come to palliative care setups where this comfort care is offered, they're drained out completely. Even financially, they're drained out. They have no money. When we say, they come to us and say, can you tell us how long he has so that we can make arrangement for his funerals? We need to arrange. We need to take loans for their funeral expenses. It's a sad thing to hear. They're not worried about the very worry that after he goes, I need to spend this much money. I need to do this. There's a social pressure on them. So they have to do all this. So they are more worried about that rather than that they have no time to grieve with dignity. They have no time. They cannot afford it. Once a patient came and said, these sensitive feelings are only for rich people. For people like us who struggle to have 3 square meals a day, these are luxuries. We cannot afford to do that. If he's going to suffer, he will suffer. I'll take him back home. Because to take back a dead body in an ambulance is much more expensive than a person who is, breathing his last in an Uber or Ola. They will charge probably as per the kilometers, whereas here to take a dead body, they charge much more. So these sort of statements are so profound. They impact you so much that it makes you revamp your thought processes. They make you, think that what's really important. What gaps are there in the care? What can be done to see that the gaps are filled? So this is where the communities, when I say communities, there's the volunteers that come in and say, we are there to support the ambulance ride for the, for the mortal remains of the person. There are people, volunteers who come forward and support the funerals of the patients, funerals of the persons. So all these things are the social responsibilities of everybody to fill the gap so that there is a continuum of care for the patient, right from diagnosis till the point that he's no more. It's not one person's job. It's not one NGO's job. It's not just government's job. It is not a hospital's job. It's not just doctor's job. It's everyone's job. It's everyone's job. Everyone should be equipped in a way that we look out for others' difficulties. We look out for the gaps in their care and help out. We might not have the resource at that moment. Doesn't matter. We can connect them to the place where there is a resource place. We can connect them to that particular place. So this is where the community has to come in and, equip and own it. And you have to believe that we all have to be good. We all have to be good. When there's no power in our house, we go out and check if there's no power in the next house. Why? Because it gives a sense of calm that, okay, we are not alone. Everybody's power is gone. So sometime it will come. Somebody is going to work for it to see to it that we have power tonight. So the same logic can apply in the healthcare scenario also. If somebody is not well, if others can come in and pitch in and help them out, only to their capacity. Nobody needs to bend backwards and help them out, but within their own capacity. It need not be just money all the time. It can be your time. It can be your willingness to go to with that person to a hospital visit and just be with them, just hold his hand to assure him that he's not alone in that process. So all this is a social responsibility. And which we have to fight exclusion and marginalization. This is a very, very, very tough thing, which is sometimes some bad days, I think it's very unachievable. It is not possible. We just exclude those sort of people because they challenge our capacity. People who are in need challenge our capacity to raise up to that level of expectation. And because it's not possible every time to challenge ourselves, because every time it's not possible to put ourselves behind and raise to the occasion, we exclude them, we marginalize them, we say, okay, they're outside our purview, we cannot do it. So this is a very, very like a social evil, like a thing. Gender issues are there here, and then financial issues are there, stigmas are there. All these things added to that particular evil. Many cases, women, when they come to us, they say, you could have got diagnosed when you were in stage 1 breast cancer. Why didn't you go to a doctor? The one thing they say is, in our community, if the wife is sick, he'll immediately get married. I can't afford to do that. My children will become, they'll have a stepmom and they might not be treated well. So I can't afford to reveal my disease. This is a society. This is where we need to sensitize them. We need to bring them together with other organizations which help them understand not just their rights, but how to handle that situation smartly, how to handle the situation in a way that it helps the family and the patient equally. So it's a very, very big challenge for the society as a whole, wherein we need to own it up and execute them consistently. It is not a one-time job. It's not a one-time scenario. It's not a one-time situation that we do for one patient, that's it, I have done great, fine, let it be. It cannot be that. There are multiple scenarios, multiple things. That's the reason this exclusion happens. You need to challenge yourself continuously, if not daily basis, as and when some information comes to your notice. How do you challenge yourself to raise the requirement or the particular expectation? How do we challenge ourselves? We get to know. So this is what, look, we are traveling, we see somebody falling from the bike and there is bleeding and things like that. So somebody has to stop, carrying him to the hospital. That's the gap that we can fill. It doesn't include money, it doesn't involve money, it doesn't involve, a lot of stress from us. It's just that, probably a little detour from the, from our travel, and a half an hour or 1 hour time loss for ourselves. But in the end, we are working for the well-being, total well-being of the society. That's when the palliative care in true sense will come into play. And then it says, unless there is trust in the society, it's not possible to promote palliative care. Unless there is palliative care, there is no trust within the society. They just feed each other. They support each other. For us to trust that our government will take care of us, we have policies. We have medical policies. And for us to know that when we fall sick, we are taken care of. We have families. We trust those families. We trust our governments with those schemes, with those benefits that they give us. But the gaps that fall, that they're invisible gaps, which the society in general expects that they be taken care by the patient or the family himself or herself. That's where the society has to come into play and make it fill those gaps to promote the trust. There is a place where you go, something beneficial will happen. There is a place which will help these kind of people. There is a society, there's an NGO. When you go, they will help the situation, the scenario. So that sort of trust, if it is built, then we are working towards the well-being of the overall society. Offers its members the opportunity of upward mobility. So we will be able to move forward in our lives, and we will be able to aspire for better things if we have the trust in place, if we have the community working for everybody's benefit. So social domain or the social support system for the patient and the family is very, very essential. Only when we are distressed, we understand who's standing by us. Only when we are sick, we become aware of our own needs. And when we become aware of our needs, we understand who is coming up to fulfill those needs. So social distress adds a lot of, it's a very big component. It adds to the, it can distress the patient to such an extent that it can lead to suicides. It can lead to, walking away from the homes and, going away, not telling the family where they're going and things like that. Unless there is a holistic society, holistic community, which is working for the holistic well-being of its members, palliative care, we cannot say that we have a good palliative care system in place. It's everybody's job. It's everybody's role. We need to do that. Yeah, this is the social domain. Next comes spiritual domain. Because we all have meaning for our lives. We know that we get up, we go about our life. There are people dependent on us for their mental well-being. If there are children who want you to be safe, that's my purpose. If there is a husband who wants his wife to be, taken care of well, that's her purpose. If there is a professor who has to go to a university or a college and deliver a lecture so that, the knowledge is imparted to the students, that's his purpose. Everybody has a purpose. The reason that we get up from our beds, the reason we start our lives, the reason we look for tomorrow. For people who are suffering, there is no difference between today, tomorrow, yesterday, day after, day after, because it's going to be the same. The pain, dependency. Suddenly, a very self-sufficient person who was always in a giving position suddenly becomes bedbound. Suddenly is in a position where he needs all the help that he was actually at one point offering to others. What do you think that scenario will do to his spiritual plane? It will cause a lot of distress. Dependency is a very loss of control. Dependency. They don't they don't have a good impact or good effect on the person, especially if they're ill. Dependency makes them very vulnerable. And dependency, not just physically, then financially, emotionally, and socially. So they go hand in hand. They cause a lot of spiritual distress to the patient. We need to understand, help him find a meaning. We have to first understand his requirements. We have to first understand how he manages difficult situations in life. Say, for example, a person who has been sick. He's a big actor. He met with an accident. What do you think will keep him up, keep him going in that difficult scenario? His next project. Okay, if I get better, I can take up that particular project. So that is the meaning for him. That's what is taking him forward. That's what giving him the strength to fight that particular period of his. So terminal illnesses can play havoc on people's minds, their beliefs and everything, their ethics, their morals and things like that. So we have to help them find a meaning for themselves. Some people say, I want to be alive till next month 15th because my daughter is getting married then. So they want to be alive till then. Their hope is to be alive till their daughter gets married and goes away to her in-laws place with respect, without he being the reason that the function is cancelled. That's very essential for him. So he works for that. He keeps up his, emotional well-being. He keeps up his, spirits and fights the disease. So we have to help them find it. We have to make it possible for them. Some people come and tell us, see to it that he doesn't die before this particular date. Because if it dies before this date, so much of investment is wasted. See that he dies, just hold him for one more week. Help us, in such a way that he lives one more week so that, some legal matters can be taken care of. So all these things from the family's perspective and from the patient perspective, sometimes they clash. When they clash also, it causes a lot of spiritual distress. Once there was a scenario where the children came and asked us if we can keep him alive till next 2-3 days because some register was to come for for some thumb print and things like that. When the patient came to know about it, so it just translated that okay, his life doesn't have meaning after he gives that thumbprint, and if people are wanting him to live, it's because of that thumbprint. So it doesn't sit well with them. So we need to understand what hurts them, what gives them hope, and do accordingly. This is not some rocket science. Palliative care is simple humanitarian approach to life. Previously, 50-60 years back, it was so integrated into the medical system that nobody knew what palliative care was. The doctors knew, the entire family, the doctors knew when the kids got married, what is hindering those, marriages, what's working for them, what's not working for them, their financial situations, everything they knew. It was holistic, it was integrated. Now the situation has come because of the volume of, the diseases and the patients also. It became more about, helping the patient medically, how to cure. But somewhere that compassion has left us, wherein a need for that palliative care to be, offered separately outside the domain of medical system has come up. But still, we don't have to give up thinking that, okay, this is happening. Probably they should be doing it and we are not, we don't have to do it. If somebody was doing it correct, probably this need not be done now. Fine, that's fine to a certain extent that it's okay. We can talk it out, but still any problem should be solution oriented. We need to discuss it, in a way that it is constructive solution. We cannot sit and, that it's gone, so we cannot do anything. That's the reason we are doing this. But we have to overcome that, that disappointment and ensure that still palliative care is on the platter for the patient. Who offers? It's the choice of the patient. Where he gets it should be the choice of the patient. How he wants it, it should be the choice of the patient. So ultimately, patient-centric. Palliative care is patient-centric. It's about the patient needs, patient's requirements, patient's wants. So palliative care, that is how it has evolved as a separate branch. And it has evolved also with the thought that death need not be addressed only through, it cannot be viewed all the time through a medical lens. Death is a social event. There are so many other factors associated with death. We need not make it all the time about medicines. Some people say, like, my father is not doing well. We know he's terminal, but we rushed him to ICUs. What does an ICU do? Does it revive him? Does it resuscitate him? No. They think that because it's the best care available for the patient, they made the provision available for the patient. That's it. What about his emotional needs? Probably he wanted to die at home. Probably he wanted his family with him. So we need to understand death not just from medical perspective, but from the patient's perspective, in the sense that we need to understand his emotional needs. We need to understand all the other needs and then make it a holistic approach. Make it, as pleasant, as pain-free, as comfortable as possible for the patient. So this is a very, very simple thing, but it has to be a team thing. It cannot be a one person's work. It's a community's work. It is society's work. Certain states, policies for palliative care are there. They're owned by everybody. Certain states, though they're not policies, there are so many NGOs working for the cause of palliative care. Because there are people who believe that nobody should die in pain. Nobody should have a bad death. Nobody should die in a way that the others who are looking at that particular process are so scared when their time comes. Palliative care ensures that before the patient physically dies, he doesn't die emotionally, he doesn't die spiritually, he doesn't die socially. Because death should happen just once, not on a daily basis, on different levels, just because he has disease. So palliative care is a very humanitarian work, which is everybody's work. That's what palliative care is about. 2 questions before us. Simple questions. These questions should be asked by everybody to themselves. How do we make sure that incurably ill patient before us is comfortable and at peace? What is my role? How can I do it? Is it possible that I give them some information about a particular resource person or a resource place or a particular, procedure that is there for them? So all these information, am I in a position to give that? Am I aware of the resources that are available in my community? Can I do that? Can I see to it that he reaches that particular source? So we need to ask them, how can I help them? How can I help them to be at peace and comfortable? We don't have to do it on a regular basis, in the sense, we don't have to do to the same patient every day. If you identify the patient and direct him to a place where he can be kept comfortable, that's a great job. That's a responsible job. That's the job of a compassionate person. And once you do that to your own family member, then you extend the same logic to the community around you. So one person is there, you're doing something. Then there are many people around us. Then how do we do it? the same thing can be extended to the community. So these are the questions we need to keep asking to ensure that we are part of a healthy community, and we take charge of that situation and ensure comfort and ensure peace for the patient. So this is everybody's responsibility once again. And this is the end of my PPT. And if anyone wants to ask me anything about palliative care, please feel free to do so. Can I wrap it up, Ravindra Garu? Can I close the PPT?
Yes, ma'am. Thank you, ma'am. For giving wonderful insights into palliative care and why it is very much required.
Yes, sir.
Participants, if you have any queries, you can raise your hand or you can unmute yourself. Yeah, Mary ma'am, you are unmuted. You can ask your query.
Hi, ma'am. Very good session, actually. It was very informative. Actually, I'm Mary Florence from Bangalore. I worked in 1 year in Kidwai Hospital in Bangalore, King Kidwai Memorial Hospital in Bangalore. That time I have seen palliative care patients. So more they give peaceful dying, and plus they give good treatment. More than that, they give counseling sessions. They speak about spiritual persons from different religions. If they're Hindu, from temple, or from Christian means church, they make the patient to die in peace, and they give lot of comforting words. If they want to see somebody in their life who they're dear, near and dear, their siblings, husband, children, some of them they have left in Bangalore. There is a famous hospital, Karnashraya, where family is rejected. They go there and they give a peaceful death. So that time end, if the family leaves also, they will ask, you want to see anybody or friends, they will bring there, and they will do good funeral, and after that also the 10 days or 48 days ceremony they do. So I have involved in lot of, and my Christmas donation every year goes for cancer patients. The every year whatever my actually for us Christmas is a sharing and giving. So I always donate my money to cancer patients, because that is the dangerous disease. I lost my own friend who's I'm 39 right now. I lost my own friend by breast cancer, and today our daughter is doing well, like she's applied for CT in Bangalore. So hopefully she gets MBBS, but she lost. Suddenly, first it started with breast cancer, then they said cervix, then they told whole body is infected with cancer. Actually, she was not a very outgoing person. How this happened, we don't know. And the parents and the people of that girl's family was not that much educated. We took her to so many hospitals, and then they told, you fulfill all her wishes, let her lead a peaceful life. So they totally shifted from Mumbai to Bangalore. Actually, she was in Bangalore. She got married to Mumbai. He's a cricket, IPL cricket camera person, her husband. So they shifted because of her doctor's advice. They took her to, came to Bangalore, and she stayed in a mother's place. They made all the relatives see her, and daughter, they confirm, they they gave counseling to the daughter that no more your mother is going to live, you should manage on her own. Now our daughter is 18 years. This May 27th, she'll turn 18. She's planning to go for MBBS. So for me, cancer means I think only, and my bad luck, I lost my father and my friend on the same day.
So
Within
sorry.
2 hours. My dad died at 8:30 and my friend died at 10:30.
So sorry.
Same November 6th. I was so attached to her, but I couldn't see her last face. Everyone told Florence, you're so close. Maybe that's why God didn't make you to see her last body was shrinked and all. Maybe God didn't made you to see. So actually, when I was preparing for my dad's funeral, I was doing arrangements, what I should invite people for, how many people, and I was making arrangements. My friend called me up and she told, I have one more bad news that your friend Chandana's passed away. So that November 6th, the day starts every day only, I'll start with tears. So actually, I felt why that girl didn't die 1-2 days after my dad's death. So I would have seen her last face, but why on the same day? Because I have a lot of responsibilities in the house because I am born with only two sisters. I'm the son and daughter of the house. So I have to do the son responsibility, daughter responsibility. So if it was my uncle or any relative also, I would have left, but it was my father. So I know what you're speaking. I've actually gone through. So this topic is very touching, ma'am, and all the best for your future and all the best for your next session. Wonderful speaker you are. Thank you.
Thank you so much. And sorry to hear what you shared, and this impact. There is a belief that we can never outgrow. We never. There's grief is something which will never leave us. We just learn to live around it. We just learn to handle it with dignity. But the pain and the profound impact that it has on our minds will never leave us.
Actually, I listen to Ravindra sir every speaker, but some speakers now it is that speakers the topics really happened in my life. So that is I would now also I ask God why you took her on the same day or my dad died. I couldn't see her last face. Now she was so attached to me. Because of her, I saw the Indian captain Dhoni, Virat Kohli, and all. Because her husband was in the IPL na for camera person. I got lot of VIPs to see through her, and I couldn't see her face. Now why God you did like that? Till now I'm asking the question to God. So it is really impacted me. So all the best, ma'am. Once again, God bless you. God give you long life.
Thank you.
Thank you, Mary ma'am, for sharing your experiences and for your wonderful comments. Any other participants, if you have any observation, comments, clarification, you can unmute yourself or raise your hand. Feel free to discuss, or you can put it in chat box. I think the presentation was so simple. I mean, it was so flowing, and we could all connect to that experience. We could visualize what kind of situation caregivers were going through, and what we need to, how we need to respond to it, and what are our responsibilities towards such situations. So definitely we all need to first become aware of such things, as you rightly mentioned, then respond accordingly. So that should be the takeaway. Thank you once again for joining us and enlightening us with the palliative care. As you said, in some states it is very actively practiced, but in few states it is lagging behind. So we need to take up in a wide manner with community engagement that can help these people who need palliative care. One query from my side.
Sure.
There are few people, this is with regard to pain management. No?
Yes.
There are many people who are having or suffering from these knee pains and other pains due to this bone related diseases, especially in old age, above 70, 80. So often they are they have undergone surgeries and they have done everything. But I mean, nothing could save them from the pain. So for those people, what you would suggest? Do not have any diseases, but only because of this grinding of bones, especially, they are going through lots of pain.
So, thank you for this lovely question, sir, because it's very, very essential for us to understand the very fact that palliative care is not just for terminal patients. It is for people with who are experiencing, pain or this discomfort, or their lifestyles have changed because of some health-related issues. Like, for example, as you said, old people, they don't have any diseases. Probably they have something like diabetes or high blood pressure and things like that, thyroid and things like that. But still, they experience excruciating pain because of some reasons like what you said, this arthritis, because bone it has deteriorated and things like that. So here we should think on the lines of geriatric palliative care. We need to understand their medical needs. So what happens, or what helps a person to lead a life which improves by improving how to improve their quality of life, and how to help that happen. So for these sort of patients, there will be some sort of pain management, sir. Pain medications are there, not necessarily narcotics and things like that. We can still go for pain management medications are there, and we can ensure their comfort, and they don't have to live with that pain for the rest of their lives. It's not needed for us to do that first. So what happens with these people is that we don't, first of all, acknowledge them as patients. When I say patients, it doesn't mean that we should look at them only through the eyes of the disease. I don't mean to say that. What I'm saying is we have to, first of all, understand that they need help. We have to acknowledge that they need help. Most of the pain, there are two components to the pain. So one is physical pain and the psychological pain. Physical pain is the pain that you're actually experiencing because of that medical situation. The psychological pain is that somebody is not acknowledging it, that your loved one or your family is not acknowledging that you are suffering. We try to write away these, geriatric issues under the blanket. We try to push it under the carpet, thinking that, okay, these things happen to old people. So, old people, then, you have delivered 10 children, and this will happen. This is bound to happen. Fine, this is bound to happen. There's no doubt about it. But still, it can be handled in a way that she doesn't experience that pain to the extent where she's discomforted, to the extent where she lost hope, or her lifestyle is affected. So to live in constant pain is a curse like a thing. So we can still help them. So we need to first acknowledge that the family needs to acknowledge that they need help. We cannot write it off saying that old people do have it. Recently, I heard somebody say that, chemotherapy, chemotherapy, it will cause a discomfort. What did you expect it? Yes, of course it is. It's a common knowledge that chemotherapy will cause a lot of discomfort, but there is a way to go about handling the discomfort. So old age will cause discomfort. There's no doubt about it. The organs or, the bones are giving away. So, but there is a way to go about it. We can still address it, sir. If you know somebody who's really experiencing that sort of pain, we can address that pain. We can ensure that, they're given comfort. Our team will visit and, we can ensure that we acknowledge their discomfort. We acknowledge that they're suffering and we can do something about it. There's so many occasions where when the palliative team visits, the elderly are so happy that, they got somebody to themselves where they can talk it out, where they can share their life experiences, which will add to their emotional comfort. When the emotional well-being happens, they get the strength to handle their physical discomfort by themselves. So we can make it happen, sir. That's not a big thing at all. That's the minimum thing we can do to our elder population, because if not for them, none of us are here. So you do bring it to our notice. There is medical team. They will guide accordingly. If something needs to be done to ensure, that pain is reduced, we will make it happen.
Thank you, ma'am. Especially when we do community visits, often we come up with this particular issue where they don't have any disease or disorder or any abnormality, but they just have some because of this problem. Because I also felt helpless at times, because even in spite of all the medication they are taking, still they take lot of medicines, even 3 times also, still their pain is not managed. At times I feel that what can we do? I mean, in spite of taking medication also, they still feel the pain. So I came across so many people like that, especially aged people.
You do
So
let us know, sir. You do let us know. We'll do the needful. Probably what is available across the counter is not helping them anymore. Something else, little more stronger, might help them. We'll make it happen, sir. And many a times I hear people say, especially one elderly lady recently told me that it's 4-5 months since somebody touched me. Somebody even held my hand. So physical, even that touch, that compassionate touch also can help. A small massage to that leg, a small massage to that, hand where they're experiencing that pain will help them handle it better. There's a psychological component of the pain is the main thing. We can help them more. With the physical aspect, let me discuss with the medical team. Please do let us know. Please do bring such cases to us. We will help, sir. Geriatric palliative care has to be addressed, and it has to, we need to take it forward. It's our duty to take it forward to ensure the comfort of our elderly people, for elderly family members. We need to do that as a team. We need to do that. So we can do that, sir. That shouldn't be a problem.
thank you, ma'am. This brings us lots of hope, because sometimes even I spoke with a few of pain management specialists also. They also said, I empathize with you, but still that is what we can do. I mean, further can, because they are healthy in all aspects, only that if we give a different medicine that can deteriorate their health and that can bring in other problems. So we are not preferring those medicines. So, I mean, they have to live with them, but pain is manageable. Still, they feel that pain unmanageable. So that is what even experts also say in certain situations. As you said,
So here, I think, sir, here most of the times, longevity with low quality or good quality with little side effects should be like, as I said, burden versus benefit should always be evaluated when we take a call. So we can definitely try it out, sir. We can, if you have a specific patient in mind, please do bring to us and bring them to us. We'll help out, sir.
Definitely.
Once it's done for probably one person, probably it will spread to many people to whom we can help.
Yeah, definitely, because nowadays the longevity has increased. So we have a very good geriatric population.
Yes, sir.
The number is also increasing, so we need to focus on them.
Yes, we need to do, sir. We need to. I truly believe that. Truly believe that.
Surely, ma'am, next time I will see whenever there is a possibility. I'll just share with you the case sheet and other things, so that if we can do something, then it will be a great help for them.
Sure, sir. It's my responsibility. I'll do it.
Ma'am, if can we have any session on these, especially on this kind of pain, so that I can, because in some old age homes also, I came across with this issue. So can we, I mean, are there any specific workshops on this specific topic, or
Like
can we organize any specific issue like this where there are no diseases or disorders, but they are only suffering from pain? So due to this
So it's called, yes, sir, sure. Geriatric palliative care is what you're referring to, sir.
yeah,
The issue itself is age. There's nothing else to it.
yes,
The suffering is because of the age. The pain is because of the age. Okay, so we can address that. So yeah, definitely I will get ready with my next PPT for geriatric palliative care and we can do it, sir.
sure, ma'am. I will also try to pinch in into few old age homes where we have such people, so that at least with that one awareness session, we can maybe address a few of them, and it can spread to other population as well.
Would love to do that, sir. Please, let's join hands to offer solace to this elderly population in our community. So we have to show to the next generation that aged people should be respected and their issues are to be considered, and that aging can be done with dignity because there is a community to support that age and that population. So we can make this happen, and you tell us where to come, when to come, we can make it happen.
Thank you, ma'am.
Thank you so much.
Duly responding to that.
Thank you so much.
For your support.
Thank you so much.
Participants, if you have any queries, you can unmute, or if you have any elderly persons at your home also, or in your neighborhood, if they are facing any issues, I think you can also ask, get clarified.
If you think, any of you think I can help you through the organization that I'm working with, for any health sort of reasons, please take my number from Dr. Ravindra Garu. We'll do the needful. We'll do the needful.
There are no queries as of now, ma'am.
Okay, sir.
Get back to you. And thank you, ma'am, on behalf of Sri Holistic Health Foundation and Sri Research.
Thank you for this opportunity, Dr. Ravindra Garu. I think after dilly-dallying so much, I think finally we connected. So for this reason, I have taken off today because this work is very time, it leaves us with less time for these things. So next time, definitely for geriatric palliative care, let me be ready with that and we can take it forward. And in case you know of any old age homes where we can offer some sort of, medical help to them for pain management and things like that, please do let us know. We are there. We are there.
Thank you, ma'am. This video is also being recorded and live streamed. So we will also share this video also to all the contacts, and so it will be very useful.
Thank you so much.
For everyone. Thank you, ma'am.
Thank you, sir. I'll take leave then. Thank you so much.
Thank you.
Thank you everyone for listening to me. Thank you.
Participants, you can find the feedback form link in the chat box. You can fill the feedback form. Within 15 working days, you will be receiving the certificate. There might be some delay, especially because we are having a lot of things in hand. So don't worry, but fill up the feedback form. Maybe you will get all the certificate at once after 15 days. So don't worry that you are not getting certificates or something like that. We have your data, feedback data. Kindly find the feedback link in the chat box and fill up the feedback form. Thank you everyone. And also join Telegram link as well as the Facebook group so that you will get all the updates, and see you all tomorrow at the same time, with the same link with a different topic and speaker. Take care. Good night.